Hi there. I'm Julie Kenville, president of the MUHC Foundation. Today, we're going to discuss a really important topic. How do we improve the quality of care in our hospitals? Technology is fast changing, especially in healthcare, and it has the promise of saving more lives and, of course, of better diagnostics. But for staff who've been in the business for decades, it can also be quite terrifying, and the stakes are really high in healthcare. Any mistake could cost someone's life. Our guests today have big plans and big dreams for the training of staff. They want the MUHC to have the best skilled team. Dr. Elene Khalil is director of the MUHC Skills and Simulation Center, and the coordinator, Carolyn White. Thank you so much for joining us today.
Good morning. Thank you for having us.
Dr. Khalil, can you tell us what exactly is this new center and why did you create it?
So we believe that simulation is very important in the education and training of our future healthcare workers, but also ongoing training of our current healthcare workers. As you just mentioned, technology is so rapidly evolving that we need to equip ourselves with the means to teach our people to provide the best care, to be comfortable with the technology. Because not only do you have to be skilled, you have to be confident. The way you perform really depends on both those things. And that's what we're seeking to do, is to create a center that will allow us to do that. We believe in blended learning. So some things you can learn by reading a textbook or an article. Some things you can learn by watching a video. But some things you actually have to just do yourself. And that's what we call experiential learning. And that's what simulation allows us to do. The other thing that it will allow us to do is mastery learning. You know, when you have a skill that's relatively complex, psychomotor skill that you have to learn, and you have to do it, before doing it on a patient, you should be able to be pretty perfect before actually trying it on the patient for the first time. Nobody would get into a plane when the pilot's trying it for the first time, right? So it's the same thing for physicians, nurses, and other healthcare professionals. So mastery learning is all about that, is about learning a skill until you have it perfectly before trying it on a patient.
But tell us about some of these challenges that you previously had in training staff.
So the healthcare team is a very busy team, right? We can't say that we're overstaffed, right? So we're functioning with the number of healthcare professionals that we have. So to release those healthcare professionals to go and do training is always a challenge. It's necessary, it's absolutely mandatory to maintain our skills and to improve our skills and follow technology, but it's difficult. So one of the big challenges has been to move the whole healthcare team off-site to a simulation lab somewhere. We had been using ones off-site, but it's really a challenge to move the entire healthcare team there. So we would have, for example, doctors going by themselves or nurses going by themselves on separate days. The fact that we are working towards bringing all that home to our own environment, to the MUHC, so that a team can leave or can be excused from their workplace for a short time, an hour. That's what we did during the pandemic. They would leave for an hour, do a scenario, practice a scenario, debrief, and get right back to work.
So previously you were sending one nurse here, one nurse there to do, I guess, full day trainings?
Full day or at least half day, because that's, you know, once you're displacing somebody, you're looking at blocks of at least 4 hours, right? Whereas here people can get away quickly, get something that's a very rich experience, and get back to work.
Now, it sounds like you've moved from having individual training for staff to having team training on site. What difference does that make?
Absolutely. That's probably the key, really. Carolyn and I, Carolyn's a nurse, I'm a physician. We work together very, very collaboratively. We believe in interprofessional learning. You know, we provide care as a team. You know, at the MUHC, one of our mottos, right, is the best patient-centered care. And at the center is the patient, and around that patient is a slew or a flurry of professionals, right? Everybody who's around that patient to provide the best care that they require and that they can receive. And so if we provide care in that way, then we should be practicing in that way too, all together as a team. So as an example, one of the benefits of practicing as a team is that we can practice things like coordination and communication, the soft skills that we can't do if we're alone, right? If a whole bunch of doctors are around a bed, that's not reality. That's not how we usually do it. So many of the gaps or errors in care are not related to the knowledge of the individual. They're often related to the coordination or the communication amongst the healthcare professionals around the patient.
Caroline, tell us about some of the challenges to nursing training. I love the fact that you've moved from nursing to skills and simulation. What were some of the key challenges and really what we're interested in as patients is the nurses are the ones that we see the most in a hospital. And the complaints that we hear the most are about the qualitative, that behavior that Dr. Khalil just mentioned. So how do you even teach that?
So a lot of the simulation scenarios, the complex care scenarios, really are situated around how teams come together and the objectives, the goals of the scenario are really tailored to the different specialties that are involved in that training. So we need to think about the physician perspective, the nurse, RT, and really give everyone a learning opportunity that will enrich them as individuals within their respective professions. We don't work in silos, we work as a team. So when a patient is receiving care, there might be a doctor at the bedside, there's a nurse at the bedside, and we might not be there at the same time, but we do work as a team collectively for this patient. So if we are not able to communicate or communicate effectively, it's very difficult to have a highly effective healthcare team when you don't speak to each other or understand the needs for that patient. So training teams to work collaboratively, to look at the different gaps, latent errors, learn how to fix these errors from happening, we can provide the best outcomes for our patient, but it means coming together. So individual training is one thing. It's definitely something that has to be done for particular skills, but how teams work, those soft skills have become much more relevant.
And inside this new center, is it all physical space, or are you also starting to develop more online modules for training?
So right now we are investigating multimodal learning. So this may be—
What does that mean?
Multimodal, I'm sorry, is different avenues of learning, whether it be hands-on technical, it might be online learning, it could be virtual reality. So we're bringing different types of learning together to sort of enrich the learning opportunities. People learn in different ways. So we have to be conscious of the fact that we want to give people as many opportunities to learn that we can. So yes, that might include online learning.
That's fantastic. Now, the aviation industry was completely transformed thanks to the integration of simulators. Interestingly enough, your new Skills and Simulation Center was made possible with seed funding that came in from CAE, a generous donation of $500,000, which included numerous equipment to get us started. Caroline, can you tell us a little bit more about that?
Yes, absolutely. CAE did make a very generous donation of equipment as a sort of a starting point for us moving forward with our simulation center. And this included several patient simulators, so human patient simulators. We have high fidelity labor and delivery mother, which includes also a HoloLens. So the HoloLens is actually a virtual reality headset that allows you to actually see what's happening inside the mother's abdomen as she's giving birth. So that brings an entirely new dimension to the whole process and learning, whether you be a nurse, a physician. We have emergency mannequin as well as a nursing mannequin. We have also received a cardiac catheterization simulator, which is set up and ready to be used by our residents. So that's very exciting. We're very, very excited about that, as well as portable cameras. So when we do go off-site or in situ, so onto a unit, we can actually bring these cameras, record the scenarios, and then play them back for our learners. So they can actually see what they were doing and then discuss that and possibly, identify gaps or latent errors or, key teaching points.
That's incredible. So you put on goggles, and from a virtual reality perspective, how does that impact your training? Can you see how the baby would potentially move depending on how you apply pressure? Is that?
Absolutely. So as the mother is actually going through the delivery process, and the physician and nurse are sort of helping her and guiding her through this, as well as performing the maneuvers to help the baby to come down and through the birthing canal. We can actually see the movement of the baby. We can see how the baby is turning, and really what the maneuvers are doing to help this baby to be delivered. So, and it's very educational. It provides a lot of information to the learner. So it's not just what you're visually seeing. There's also sound and description of the process and what's happening.
Those would make great video games as well.
Yeah, they would.
Another business to develop.
But
Dr. Khalil?
It's very interesting because if you go back 20 years, how we used to learn is by looking at pictures and atlases and textbooks, right? We've come such a long way, and it's different from watching a video because it's actually interactive. The scenario responds to whoever's manipulating. So you can just imagine how much that gives, especially when there's a complicated birth, that gives to the people who are actually doing the delivery. So you can prevent bad outcomes by practicing that way. We're also exploring, I don't know if you want to say a word, but about that, we're exploring the use of like the HoloLens and other augmented reality and
What is a HoloLens?
Do you want to take this one?
Absolutely. So HoloLens is actually, it's a headset that looks a lot like a pair of glasses, but you can actually see overlaid on top of the reality. For example, you have your birthing mother in front of you, and you continue to see the birthing mother, but you're actually able to see inside of her abdomen. So you would be able to see the baby, the positioning, the movements inside. And as Dr. Khalil said, this can actually help the physician to deliver this baby with much less harm or difficulties during the delivery process. We can use it for other things as well. So we can actually train people how to use technology by having them wear this device that actually walks them through it, so they can actually look at the ventilator, for example, and the programming that's in this headset will help them go through the process of programming, for example, how to troubleshoot the machine, which is something you really don't want to do when you are with a live patient. This is something you want to know how to do before getting there. So there's many different applications. We've also—
Can you give us an example of an application?
A ventilator would be a perfect example. So hooking a patient to a ventilator, the programming of the ventilator, taking a new nurse or a resident through this process before they actually end up in an ICU setting where they may have to do this.
How did you learn before? Dr. Khalil, when you learned how to use a ventilator, you're an emergency room physician. How did you learn how to use one?
People would tell you, and you just tried to remember, you did your best, and then the next time you were in front of a machine, you tried to remember what they told you and look at your notes. We took lots of notes, but it's different. Experiential learning really, it's proven to be much longer lasting, especially for adult learners. It's the way to learn. It's by doing, and by doing it over and over and over again until you're actually good at it.
Now, we're a teaching hospital here.
Yes.
What impact does the Skills and Simulation Center have on that aspect of education?
Absolutely. You raised a very important point. We have an academic mandate, and our academic mandate rests on training future generations of healthcare workers, on keeping the healthcare workers that we have currently up to date and on point with the technology, and also research and innovation, mandate as well. So that if we're not evolving with the technology, there is no way that we could innovate, right? So it keeps us at the leading edge of technology and of science and of medicine, so that we can provide the best care. So that's a very important mandate. A Skills and Simulation Center will bring that technology in. As a very concrete example, I'll give you, during COVID, right? We used to go into a room. Let's say I'm an attending physician, and I would go in with a resident, 2 students, maybe the nurse educator, and another nurse who's learning. So we're about 8 people going into a patient's room. This is not possible anymore with COVID. Mm-hmm. So we have to rethink the way we're teaching and learning. And so the HoloLens would be an example of a way that technology can help us to teach, so that you have, for example, I would go into the room with the student is wearing the HoloLens, and we have 8 learners in a room watching what the student is seeing and learning that way, relatively remotely. So in other words, they're not in danger, they're not exposing themselves to somebody who has COVID, but they're there and they're learning. So we have to explore these new technologies that will allow us to be more efficient, not necessarily to work harder, but to work better.
Are patients concerned about this new technology?
Well, we don't expect that they will be, but I think it will be an adjustment. It will be an adjustment because having people come in with a big HoloLens on will be strange. But also, it was strange to have people come in a visor, a mask, and the full PPE. But people are getting used to that too. It's for their own safety.
So why should patients care that we've created this new Center for Skills and Simulation?
Well, I think the importance for the patient is maybe not so obvious off the bat or at front. The assumption I have when patients come to the MUHC is that they're expecting really top-notch care by top-notch teams, which we do have. And we do a lot. We do a lot, but I think we can even do more. As everything evolves, and we mentioned this before, that technology evolves, each patient arrives thinking and assuming that the healthcare teams know everything about that technology. And they do, and they should. But to practice, to allow them to feel confident, will allow the healthcare team to deliver that best care. So I want the patients to continue to be confident that when they come here, they're really getting the best care. And I really feel that allowing skills and simulation practice on our site is going to provide that and ensure that.
Caroline, Dr. Khalil mentioned obviously the massive changes due to the pandemic and to the care that has been offered at the MUHC. How has the pandemic impacted your own job?
The COVID pandemic has really made us realize that the need for ongoing simulation, education, and training on site at the MUHC is incredibly valuable to the care that's being provided to our patients.
I was just going to say, just to give you an example, sorry, I just wanted to a specific example that might reach out to people. During the pandemic, there was a series of activities. Everything was placed, all the focus was placed on COVID and COVID response because it's something new. All the protocols changed. And there were areas of activity, not only at our hospital, globally, whoever has been affected, that had to be stopped. So, for example, certain cancer surgeries, cardiac surgeries, and so on. There's, ambulatory care. A lot of those activities were stopped. So there was a group of healthcare workers that were not so busy during that time, and that group of healthcare workers were redeployed to areas that had to respond to COVID. So, as an example, some pediatricians or, for example, a gastroenterologist who hasn't treated a pneumonia in many years was suddenly working on a COVID ward. And so they had to treat, they were outside of their scope of practice, of usual practice, of an expertise. And so those healthcare professionals needed the support to prepare for that. So we prepared, in fact, we opened a COVID Learning Center on our intranet. We prepared education bundles to help those redeployed healthcare workers learn quickly, because everything was very fast, learn quickly the science that they needed to know to go and respond to those COVID wards. And Carolyn was instrumental in deploying the simulation aspect of it. So we coupled online information with simulations. And so maybe that's something you can mention, because I thought that was a great success.
Yes, we did have a lot of demand for simulation, and we actually did simulation training from the beginning of the COVID pandemic all the way through, and we continue to do that training now. So we're still in the process of providing training to staff, not only at the Glen site, but at other MUHC sites as well. So we actually do mobile simulation where we're bringing it to the learners in their area. We've done simulation in tents. We've done them in CCU. We've gone to the neuro and spent time with the staff there, not only doing a deteriorating patient scenario, but also a cardiopulmonary resuscitation, always with COVID in the background, a patient that may have COVID or does have COVID, or we must suspect that they do. And with the policies that are continuously changing as we learn more about COVID, it affects the policies and how we actually provide the care to the patient.
But that must have been incredibly challenging. Information on COVID was fast changing and policies were changing almost on a daily basis.
Absolutely.
So how did you manage to update your material that rapidly?
Well, we did have a very effective team. We had several physicians that volunteered. We had nurse educators. We did have a core group of nurses that actually volunteered to help support the simulation activities by doing the setups, running the simulators. And together we were able to ensure that any new policy that emerged, that the scenarios were altered to incorporate this, and that our debriefing, so the discussions we have post-scenario, really tried to clarify any major points that staff might have had difficulty with, because we were really doing things very much differently, and we continue to do so, than what we've done before. So it's also staff relearning skills they know very well. So you have very competent, expert clinicians who are now having to deal with policies that change within 24 hours. So a policy came out yesterday. Today, the same policy is no longer valid. So they have a new policy to adapt to. So the information input was huge for staff. So having these continual simulations really had a great impact on our patients, the care that was provided. And we saw healthcare professionals coming back time and time again, if not to participate in the scenario, to listen and participate in the discussions and the debriefings so that they could remain up to date and provide the best possible care. And when you see staff going through a simulation, and as the simulation is finishing, there's a code blue, which is cardiac or respiratory arrest.
A real one.
A real,
actually happened
live twice with a real patient. And they are now leaving that simulation training education session to go and respond to a patient who is in arrest. They actually were coming back to us where we were set up to say, we had the training, we left the training because we had to respond to that exact situation we just encountered. And this is what we implemented. Because of this, we were able to do this differently. This is the amount of time it took us to get into the room now that we know the proper steps and we're more efficient in doing it. Mm-hmm. So that makes an entire different outcome for that patient.
Mm-hmm. The response to the pandemic, I think maybe the public doesn't really see that so much, but it rests a lot on patients. So the healthcare workers want to respond, right? That's what we are trained for. We want to treat patients. That's what we want to do. Now there's this new element that the virus can actually be dangerous to us. Mm-hmm. So there's an element of self-harm potential. So you can understand, I think, that then the confidence becomes so paramount that the staff have to be confident that, yes, I'm adequately protected, that the protocol is based on science, that the policy change, yes, it's changing quickly. As science was evolving on COVID. We know a lot more now than we did 5 months ago. But the policies change, that undermines confidence. But as long as you're confident that it's solid, it's based on science, you're going to do it and you're going to respond properly, and it's going to increase your confidence and therefore improve your performance. So that's where I think it makes a big difference, that the simulation that Carolyn and our team put together. So
we saw across the province that healthcare workers were the hardest hit by the pandemic. In fact, how did we do at the MUHC?
We did actually quite well. I'm very proud, and I'm very proud of our infection prevention and control team. So I sit in the coordination center, which is the deciding body, the deciding committee during an emergency situation for an institution, and they held expectedly, they held a very important role. And so they were fantastic. I won't name them because there are a whole group of them, but they were really great.
And I believe that there's been very little cases at the hospital as well. Can you tell us how we are preparing for major disasters like pandemics? And of course, the MUHC was a key component in the Dawson crisis and has lived through some major crisis. What did we learn, and how are we preparing for the next ones?
So our emergency preparedness of our institution is really based on an all hazards approach. You mentioned just in one sentence several different types of hazards. We hope to never see that, things like Dawson in a career, but unfortunately, likelihood is we will. We have different vulnerabilities. We've done vulnerability analyses. We know what we need to prepare for, and that approach allows us exactly to prepare for all those types of things. And simulation plays a big role in preparedness. You mentioned disasters. So, unfortunately, when Dawson happened, we had already started simulations, but we weren't yet doing large-scale whole hospital simulations like we do now. We do them about every 2 years because they are a huge production. They take around 10 months to prepare, and I can't even tell you the human hours required to do it. But we do it on a very small budget, but we do a lot. We could do even better if we could increase our technology, increase our space use.
But Dr. Khalil, the pandemic has transformed all of us. We have to be very honest about that. Did Dawson transform healthcare workers here at the MUHC?
I think it did. Whenever these kinds of events occur, and even after our simulations, we debrief. We have a hot debrief, a cold debrief, and then an after-action report that comes out. And so it changes the way we do things. We learn from every single episode and situation. Right now, as an example, post-pandemic, first wave, we don't know what's coming, but after this first wave, we're in the process now of debriefing. Our CEO is surveying different people. We've created a quality improvement type of a survey that we did actually at the peak of the pandemic. We've just finished analyzing those results in order to better prepare for the second wave and to learn and teach future generations about how to respond to pandemics. So that's just the pandemic. Pandemic is a little particular because it's long over time. What you were referring to, like the Dawson tragedy, is more of a code orange. So code orange is a code that we call, we have a series of emergency codes in the hospital. It's a code that we call when we are expecting a massive arrival of victims. They can be trauma victims, they can be intoxications, and whatever. But we've had a few. We had a carbon monoxide intoxication in a school where we received about between 15 and 20 patients, pediatric patients at that time. But these things happen periodically. They are rare, but they're high impact events. So how do you train staff to be ready and to be expert at responding to a rare event, but it's very high impact? It's simulation. And the way to do it is really to do it in situ. So, we talked about a little bit of simulation in labs. Then we have simulation in a center, which we're right now in the process of creating, because you do need that. You need an active learning space. We need space to house our high-tech equipment. We need space for people to come and be able to use those mannequins and that equipment. But we need a space where we can run a scenario if the space is not available, which has happened. Because if suddenly a ward becomes a COVID ward, you can't access it anymore. So you need to run the scenario in a different place. So we need that space. But ideally, things like Code Orange, we run in situ. So in the actual work environment with a huge number of benefits to doing it that way.
Caroline, what are the greatest challenges in setting up? You've been here since the beginnings of this new center. What are your greatest challenges?
Some of the greatest challenges we've experienced is, especially since COVID, is the large demand for assistance with simulation. And we're actually seeing that having simulation on site, in situ, is really important. We're seeing a huge transition from external simulation centers to on-site training. And there's a difference between the two. One is really tailored towards the students that are within the schools that are learning their profession. And the insight in situ is for the clinicians that are working and providing care to the patients here. Well, some of the biggest challenges has actually been being able to respond with the appropriate equipment, not necessarily having the equipment on hand that we would require for this education, as well as space. So when you have, for example, GI specialists that need to practice how to safely perform endoscopy, but you don't have an endoscopy tower, or you don't necessarily have the appropriate simulation equipment, you can't support these demands, but they're there. And with the closure of universities and colleges, which also limit the ability for the learners to practice, to engage in team trainings, we're now scrambling. And to a certain extent, we're doing the best that we can, but we could always do better.
Now, how do you fund a center like this? It sounds like it is essential to learning and to improving the quality of care across this province. Is the Minister of Health involved? Is he funding your activities?
It's a great question. So what I can tell you is that the leadership and the CEO of our institution, of the MUHC, absolutely back our development of skills and simulation center on our site. And so we're very lucky in that respect that we've had that support. But unfortunately, the operating budget of the hospital doesn't cover that. So we do need to look externally for funds to help us develop that.
Well, thank goodness for CAE. So hopefully someone in the audience is fascinated by what you're doing and will be able to help you. Can you tell us where the future lies? We said that you have some equipment needs. You mentioned endoscopy. What are the next steps? Where are you going?
We need to really develop a center that is an interdisciplinary center. We really need to ensure that we are bringing in the interdisciplinary team training. Virtual reality, the incorporation of immersive simulation, having virtual reality simulators for surgical processes. These are very much in demand to help support the learning of our residents and our nursing staff, as well as our RTs. So we are seeing quite a technology boost, but it's really in support of the education.
And we're really engaging with all the educators across the different sites of the MUHC. There's an incredible interest. And the thing is that really it's just a question of channeling that energy, because people have been working in silos. And we're in the process of bringing everybody together, supporting them technologically, and they can do amazing things with that.
Dr. Khalil, Caroline, thank you so much for joining us. You can visit muhcfoundation.com to ask your questions and find out more about next week's show. Thanks for listening. Stay healthy.